Okay, I believe we can start the webinar now. That sounds good. Yeah, dear ladies and gentlemen, good morning, good day, good evening to all of you. My name is Stephanie Thiele from Dräger, and I would like to extend our warm welcome and of course thank Dr. Abashi for taking the time today to elaborate on the topic of Aprv. Before we start the webinar, I've got 4 technical issues briefly to run through. After the presentation part of the webinar, we will open the chat function again, so everybody can type in their questions and Dr. Abashi will answer verbally. This will be open for 30 minutes, but after that we can take some questions if there is need off record as well. Please note that this webinar will be recorded and is available for download on the website shortly hereafter. And one further point to our US participants, we will send out an evaluation form to all participants. However, for the CRCE accreditation, you will need to send this back to my colleague Edwin Coombs. And with the question and answer session, I will type in his email address. So for all of you to answer this so you can get the accreditation accordingly. Thank you very much for your attention, and I will now hand over to Dr. Abashi for his presentation.
Welcome everyone. We are going to talk about Aprv today. I have a lot of material to cover, so I want to go ahead and get started. Now, as anything gains popularity, many misconceptions emerge, and in some circles, Aprv is viewed almost as a satanic mode. And as I read the more current literature, I see that many people, many novice users in particular, apply their own methods to Aprv. So what I'm going to do today is refer specifically to the method of application that we have been using clinically extensively for over 17 years and recently validated experimentally. So I want to take you through sort of the history of Aprv at my center, at the Shock Trauma Center in Maryland. We started using Aprv primarily as a rescue mode. We started an ECMO program, and we started using it predominantly during ECMO as a way of resting the lung in a CPAP type of ventilation. What we realized was that many of our patients that were referred to us for ECMO actually never needed to go on ECMO, and they had a very high survival with just Aprv. So we started using Aprv earlier and earlier, and this is about 1993 to 1994. As we continued to use it earlier and gained more experience, it became our standard of care in 1994. For patients, any patient requiring ventilation from intubation. The reason why we have such a large clinical experience is because we use this routinely. We no longer use it for rescue, but we actually apply it to any patient that's intubated. And so from a conservative perspective, we have really a very, very large experience amassed over the years. About 11 years later, we decided to publish our experience and our methodology, including, of course, our learning curve. In 2001, actually, we published looking at our institutional data, looking at 2 groups of patients between 1985 and 87 and 1993 and 1995. And we noticed that despite increasing age of our patients, statistically significant increase in the age of our patients, our ARDS rate and mortality was going down. Now, many things, of course, happened during this time, so it's hard to isolate exactly what resulted in the reduction in mortality. But one of the things was certainly applying a new method of ventilation, which was Aprv. Now here's a more recent look at some of our patients. These are 227 patients with injury severity score of 28. And these are some of the characteristics of the patients. Many of them are in shock by lactate levels, a lot of intravenous fluid, a lot of blood products, all associated with ARDS. And what we found over the years is that our need for ECMO significantly decreased, as well as it was very difficult to actually enroll patients in ARDS studies, even though we were one of the largest trauma centers in the country, and certainly the busiest. So here's looking at more institutional data. We've continued to have a decrease in our ARDS rate significantly over time. And again, it's hard to isolate exactly what caused this, but certainly the routine use, standard of care use of this type of ventilation was utilized during this time. Now, if you compare this to trauma ARDS in general, now just trauma ARDS, not all ARDS, just trauma ARDS, looking at national rates and looking at injury severity score, you see that despite having a high injury severity score equal to the other centers' published data, that our ARDS rate and mortality is actually lower. So this is sort of what led to our further need to look at APRV and apply it more commonly. Now what I'd like to do now is actually just show you some videos of actually how we use APRV in our center. And this is just some examples. Now this is typically what we do with APRV.
Go ahead.
Because we use it from intubation all the way to extubation. We use it in severe respiratory dysfunction all the way to the weaning, and in this case you can see ambulatory patients. And the patients are quite comfortable breathing. I guess you could argue their work of breathing is high, but that's only because they're walking around. And
Let me just
we
go
can see
behind
that
you.
this particular patient has a PCA pump, pain, has chest trauma. You're going to see in a minute here some chest tubes. They're actually on the ventilator. The patient has bilateral chest tubes. And so this is one of the ways we use APRV, of course, is that it allows patients to be quite flexible in ventilation. In fact, this patient's going to go ahead and clean their own hands, which is always a good thing. Now, just very quickly, some of our patients have taken this to a bit of an extreme, and in fact, one of our patients, which I'll show you here, in a moment. Now, this particular patient, also a trauma patient, who you can see here, you'll see here in a minute coming up in the hallway, was doing several laps around our unit, 24-bed unit. So walking around, and actually quite vigorously walking around, to the point where it was very difficult to keep up with this particular patient. And again, all patients are generally comfortable on APRV, certainly don't necessarily need zero sedation, but certainly need a significantly reduced amount of sedation. And again, I think a lot of this has to do with the specific methodology, which I will elaborate on as we go further into this. Now, just to show you a different extreme here, this is a particular patient who was referred to us from our own medical ICU, and the patient actually was an H1N1 patient that was placed on ECMO and received continuous dialysis and all kinds of interventions because of their acuity. But you can still see here the patient is breathing comfortably on APRV, and you'll see a better look at the patient here in a moment. Then the patient, if you look at their patient, is actually proned on ECMO, on dialysis. So you can see that we use APRV in the full spectrum, and we basically go from CPAP, as I would call that, CPAP with APRV is CPAP with release, and then of course you just get rid of the releases and you just simply have CPAP. Now, why do we want to investigate other methods of ECMO? Of ventilation? Well, certainly the mortality of ARDS in general has gone down over the years, and it may be attributable to several reasons. But the overall rate is still relatively high. So many people still die of this very lethal disease. In fact, if you look more carefully, the bulk of the mortality drop was actually before 96. And since then, we've had a relatively stable mortality rate. Again, less than it was, but still relatively stable. And this is despite several studies, several big studies, multiple funding, a bunch of animal data that suggests various techniques may be helpful that just don't translate clinically. So this has been rather frustrating to improve the mortality overall. Now, for a moment, I just want to talk specifically about the methodology because I think this is important. I think this may be confusing many people in general. And I think it's important to understand that the ventilator placed in the mode Aprv is really just a name. And so the lungs have no idea physiologically how to respond to a name. What they do respond to is pressure, the duration of the pressure, lung inflation, lung deflation. Those are the physiologic consequences of ventilation, not the name at all. In fact, here's an example of an airway profile and the flow profile of two different patients. And you can see that they look almost identical. But when you really look at it, you'll see that one patient is actually an SIMV and the other patient is in Aprv. So the way you set Aprv may actually be no different than pure pressure control. And so the difference is really in the airway profile. And I think this is really key, and this is based on some of our understanding of how the lung behaves in general. So just to show you how we typically use it, we use Aprv almost as a near CPAP type of ventilation. And you can see here that the duration of the inflation is extended. And the release or the interruption of CPAP for ventilation is very, very brief, with the idea that you're retaining a portion of your CPAP level. And so we are really trying a modified version of CPAP, or you might even call it intermittent CPAP, one of the earlier names of Aprv. So let's look at this a little bit more carefully. If you take the pressure and flow, which again is what the lung responds to, and you look at it more carefully, we are actually extending the time without extending gas flow or volume. There's a no flow state over a period of time. And what we're trying to do is equilibrate the lung volume so that the lung has an opportunity to fully recruit itself. And this may be key because one of the reasons that we may want to manipulate an airway profile is to sort of match the physiologic response of the lung. So if we look more carefully, this is the difference in the methodology of Aprv. We are trying to create almost a near CPAP. In fact, if you look at the cycle time, the CPAP phase is present at least 90% of the time, over 1 minute. 90% of the 60 seconds is in the inflation phase. Now, secondly, we don't actually set a rate, even though we produce a rate by adjusting the times for inflation and deflation. So it's independent of a ratio, as would be more typical. And the end expiratory lung volume now is controlled by retaining a portion of that CPAP. So what we're trying to do is release the pressure down to a certain level and then back up again. Now this is dictated by the flow of the patient, not necessarily the pressure. And of course, one of the other potential benefits that I see is that we can have unrestricted and unassisted spontaneous breathing, which we'll get into a little bit more later. Now, back to the airway profile. The airway profile of having a near continuous pressure really is a function of how the lung behaves to inflation. And if you just look, as you hold pressure, the lung continues to recruit and it becomes stable. In fact, it takes a significant amount of time for the lung to stabilize. As the lung gets more stable and as the alveoli get more stable, this may actually be beneficial in preventing or limiting the ventilator contribution to lung injury. And that was a mouse lung, and then we'll look at it again. And these are all courtesy of Gary Neiman, these videos. And now hopefully we'll look at it at an alveolar level. So we can see the time-dependent nature of recruitment. And again, recruitment might be another way of saying lung stability or alveolar stability. And of course, it takes time before your airway pressure, your applied airway pressure, actually equilibrates with the alveolar pressure. And this is why it may be critical to extend the time. So we know that the way to recruit, or the recipe for recruitment, is pressure and time. And this is what we're trying to mimic with APRV, near continuous pressure and time. Now, what are the benefits of recruitment? And certainly you can say that there's disadvantages of recruitment, such as the fact that almost always you need additional airway pressure or sustained airway pressure. But the benefits are that we can have a more efficient lung. That means generally better gas distribution and better gas exchange. The toxic part of ventilation, certainly less talked about these days, but certainly FiO2 has been considered a toxic adjunct to ventilation, as is ventilation. Now remember that the lung has to undergo deformation. Every time you breathe, your lung is deforming. It is changing its shape and size. And so as a result, it develops stress and strain in the tissue. And of course, as this develops in a diseased lung, this may actually load the lung in a different distribution than you would normally want to have. Now, FiO2 can cause more instability, and this is considered another way to produce lung instability, which is washing out the nitrogen. So high FiO2 concentrations may actually lead to instability. Also, just pure minute ventilation, we know that cycling the breath over and over again potentially could injure the lung. And so just a simple reduction, this is an example, a reduction of 2 liters of minute ventilation over, say, a 10-day course of ventilation is 28,000 liters of ventilator stress that you can eliminate simply by reducing ventilation. This may be, of course, the notion behind permissive hypercapnia and so on. But certainly if you have efficient gas exchange, you certainly don't need to ventilate as much. Another form of alveolar instability is surfactant. And maybe by having less cycle time, and in fact spontaneous breathing may be associated with preservation of surfactant. These are also important things to consider, because what we want is a stable lung. We want lung units that are stable and will behave as they get strained. They develop the least amount of stress in the tissue. Now I just want to focus a little bit about ventilation again, and this is a volumetric CO2 tracing. Now this is from the lab that we are involved with up in Upstate Medical Center, Gary Neiman's lab. And what we're doing here with pigs is we're actually ventilating them with conventional ventilation. You can see the blue line here is conventional ventilation. And that line shows that as you exhale, you can see that there's a little bit of dead space because the end tidal CO2 does not rise initially. And as it goes up, you see eventually the end tidal I'm just getting my pointer here. You can see that the end tidal hits 40. Now we switch these animals over to APRV before we do the experiment, and you can see that there is actually very little dead space. In fact, one of the things that APRV differs from conventional ventilation is it uses diffusion and convection, not just bulk ventilation or convection. And you can see that there's more, the CO2 rises immediately because there's less dead space, because during that breath hold, you actually equilibrate more CO2. So Previous published studies and more recent studies suggest that CO2 is more efficiently managed with APRV. We typically see much lower minute ventilations. Again, potentially decreasing ventilatory stress. Now here's a porcine lung, and this is a tween lung model where the lung has been injured, and 6 hours later you can see with arsenate ventilation there's a lot of dependent collapse. That's the discolored purplish area here. And here you see the more aerated lung, which is non-dependent. And if you think about the healthy lung can really absorb a lot of stress and strain, and it distributes it over a huge area, and that's what buffers the potential to injure the lung. When the lung gets smaller, of course, the area that you can potentially injure becomes more magnified, and so the lung will load in a different region. And this may be important in terms of stress distribution. And of course, this is what fuels low tidal volume strategies and so on. But it may be a little bit more complex, and there may be more interplay between the distribution of ventilation than just simply tidal volume. And this may be one of the reasons why recruitment may be beneficial. Now I want to show you another slide here. It's a little bit off the pathway here, but this is a model of stress and strain. And so the stress comes in the form of a crushed car, and they're going to be placed on eggs. And the eggs, of course, are going to develop the strain.
There are only chicken eggs holding up a whole car.
Because the eggs are numerous in their configuration, in fact, that double arch is a very strong.
Oh, I can hear cracking again.
Also, the lung is a very strong shape. The lung is a honey lung. It's also very strong.
Some rather intriguing cracks I can hear now.
It distributes the stress evenly.
These eggs
So
are delivered.
recruitment may actually be very, very
That's
important
two
to
cars.
stabilize the
I
lung
think
and
we
actually
proved the point.
decrease the stress.
Thanks to their double
We're worried
car,
about
these
the
eggs are
stress of
supporting over
overtension.
1.5 tons.
But the bigger the area, the load is going to be less magnified. Now here comes the de-recruitment, and you can see as you de-recruit or decrease the number of lung units, now the strain can develop more stress in the eggs, and actually they fail. And in fact, ventilator-induced lung injuries, perhaps best considered a type of tissue strain injury, or alveolar stress and strain failure. Now, here's another thing I want to demonstrate in terms of stress and strain. Now, this is actually looking at recruitment, and actually this paper is really describing alternative pathways for recruitment. Another reason why sustained pressure may be important, because we have audio here. Is that better? Okay, we got our audio back. As I was saying, this paper describes recruitment and looking at alternative paths of recruitment, primarily collateral channels of ventilation, and that they may be important. And of course, this is important at higher lung volumes, is important as you hold pressure, because they tend to be high resistant pathways to gas flow. And so holding pressure might be important in these particular pathways. But what I really want to point out here, and you can see these red arrows here, this is what's considered a mother alveolus here. And where this red arrow is, there's going to be another alveolus, and in this paper they term that the daughter alveolus. And you can see the daughter alveolus, a little sliver right here, inflating progressively. And now you see that it's recruiting. Now, what you may not have sort of paid attention to is that the alveolar size of the mother alveolus is actually progressively getting smaller as it recruits its neighboring alveolus. And this may be important to share the load. Again, going back to that egg model I showed you, this is sharing the stress. And so why don't we look at that as a video, and you can actually see it. Hopefully you'll see it here. Okay. So you'll see the actual dynamic recruitment here. it's a little bit better in the slow motion version, which is coming up here. Now watch for the alveolar size actually shrinking, the mother alveolus actually shrinking as the inflation occurs. And again, as you share the load, you may actually decrease the strain in the tissue, which is really potentially very, very important. So this raises the question of not just tidal volume, but lung volume, and how is gas distributed within the lung. Now, I want to show you some of the experiments we've been doing on Aprv, and I want to talk about, again, the stress, strain, as well as amplitude. And this is one of our pigs that was ventilated with Aprv. And we just finished a 48-hour experiment, which I'll discuss later on. But I want to show you what Aprv looks like outside the chest. And we'll get set up here in just a second. Now, the important thing to remember here is we're releasing from a CPAP. And I believe it was about 24 here to a pressure of 0. And of course, many people would say that should result in high amplitude ventilation and a lot of stress injury and a lot of airway closure. But what people are forgetting about is that you can control end expiratory lung volume with time. So you can see that the lung barely moves. The lung barely winks from its CPAP position to its release. And so the lung volume is actually very, very stable. In fact, if you look at the mean airway pressure as an indicator of mean alveolar volume, you'll see that Aprv is one of the few modes that actually the peak airway pressure and mean airway pressure are almost identical. And so the stress strain, which may be important, if I were to summarize a lot of ventilator-induced lung injury, one of the things that seems to be very important is high amplitude ventilation. That's why high inspiratory pressures, sometimes generated by tidal volume, and low PEEP can actually generate a lot of lung injury. In fact, that's probably the most efficient way to injure animal lungs in the lab. Now, you certainly don't have to take the lungs out of the chest to really figure this out. You can actually just observe the patient. And this is one of my patients post-op, hopefully here in a second. Okay, here's one of my patients post-op who's not breathing.
Head got hit, denied loss of consciousness, showed up, he was hemodynamically stable, had a lot of pain, specifically in his extremities.
I don't know if you can see it. You can see the breathing, but you can see that as the release pressure occurs, the release phase, the chest stays very, very stable. In other words, there's very little reduction in lung volume. Now you can see, of course, that the chest wall and the lung are intimate. And so any movement in the lung is predicated by movement in the chest. So you can see that the amplitude is actually very low in Aprv, and this may be one of the critical things that may actually prevent lung injury.
Left arm and right leg reduced.
Now this is this is actually an injured rat lung, and I want to show you this is something we've done recently. The camera is a little bit unstable, and I just want to show you what happens when you go from SIMV. You have a little bit of rocking here. But we're going to switch over to Aprv, and I just want to show you what happens at the alveolar level. And you can see recruitment and hopefully stability. You'll see once the lung is recruited, it doesn't tend to move very much. Again, if we decrease amplitude, there may be a potential benefit of that. Now, if we talk about ways of protecting the lung, of course we have to talk about the ARDSNet. And the ARDSNet study, of course, showed a reduction in mortality. And this was the conclusion of the ARDSNet trial, that the ventilation approach designed to protect the lung from excessive stretch is what resulted in the improved outcome. And that's actually widely believed, that that's the reason for the improved outcome. If you look at it from a mechanistic perspective, it's not exactly that crystal clear. In fact, there would be several questions raised. For example, none of the low tidal volume studies, ARDSNet and otherwise, have ever shown a reduction in macroscopic barotrauma. You would think if the lung was less stretched, then there would be less barotrauma. But actually, barotrauma would probably be not a good indicator because we have the ability to look down a little bit deeper. In fact, most of this is defended by the notion that there is biotrauma or microscopic lung inflammation, and that's really what improved the benefit. Now, of course, recently in the lab, Gary Neiman recently published this particular paper comparing these open techniques with low tidal volume strategy. Of course, the idea is do you ventilate the de-recruited lung and actually not try to recruit it, and that's how you decrease the potential injury, or do you actually fully recruit the lung and actually stabilize the lung, and is that the way you protect the lung injury? So looking at inflammation, comparing open techniques to low tidal volume strategy and looking at BAL fluid, TNF-alpha, and IL-8, a chemokine, you can see that when compared to high frequency, and this is a recruitment maneuver using a technique described by Borges in the where you use significantly high plateau pressures to fully recruit the lung and high PEEP, APRV actually had the lowest lung inflammation compared to these others. This is a 6-hour porcine tween lung injury. Now, what's even more disturbing about this is that the tidal volumes used in this APRV study were actually 15 mLs per kg. And this, again, would raise the question of mechanistically, what is the reason for improved survival? Is it simply tidal volume, or is there a way to decrease the strain in the lung tissue and distribute ventilation over a better area? In fact, if you take this a little bit deeper, you can still have overinflation, and this is a human study, but there's certainly some animal data that suggests this occurs as well. The amount of collapse in the lung may be what drives hyperinflation. In other words, the assumption is that the small lung or the baby lung will stay that size, but there's nothing preventing the lung from progressively shrinking over time, so the baby lung becomes even smaller and smaller. And in this picture here, you can see that blue is represented as inflated lung, yellow is a transitional, and of course green is going to be more collapsed lung. And in this particular case, you can see 6 mLs did not produce a lot of overinflation, as it occurs on this other side where you see overinflation represented as the red. Of course, this is a depiction of Hounsfield units, a graphical depiction of Hounsfield units, but you can see that the collapse may actually be as you inflate the lung. This is end inspiration versus end expiration down here. You actually can still have overdistension by Hounsfield units despite low tidal volume strategy. So maybe we actually should consider early stability of the lung and maintaining that stability over time. Now, I do want to talk about APRV and spontaneous breathing. And this is, of course, one of the key features, I think, when I think of APRV, and this is one of the things we try to do. We actually try to institute spontaneous breathing within 24 hours of either admission or post-operative states. And we believe this is beneficial, and I'll address some of the other issues that might pop up here with spontaneous breathing. Now, one of the key things about spontaneous breathing that differs from mechanical ventilation, and I've just shown a depiction of the airway profile in a pressure mode and the flow of a pressure mode compared to volume ventilation. And in either case, you have a baseline pressure here as a PEEP level, and in order to develop flow, you need a pressure differential, and so the pressure has to be elevated above the baseline. In other words, you apply airway pressure to actually create that differential pressure in order to get volume into the patient's lungs. And of course, the flow pattern differs from a pressure mode to a volume or constant flow mode. Now, the difference about spontaneous breathing and unassisted spontaneous breathing is that there is no pressure elevation on the airway pressure side above baseline. In fact, it's the pleural pressure that changes to generate flow. And you can see that the flow is generated, but the airway pressure is very, very stable. So the pleural pressure is what drops in order to drive a differential pressure for volume into the lung. Now, this is one of the reasons why several studies have shown better gas distribution with unassisted spontaneous breathing versus assisted spontaneous breathing, which is anything from mandatory ventilation to pressure support ventilation. And the reason might be that we're pushing gas into the lung versus pulling gas in the lung. And I just want to show you a couple examples of that. This is conventional ventilation, paralyzed, and hopefully it'll be playing here. And you can see that there's already some basilar atelectasis here. You can see also that the chest wall, the anterior chest wall, moves very easily, has a big excursion, and you can see this on your patient. As they use more, as the gas distribution is progressively non-dependent, you will see more swing in their anterior chest. Of course, our chest moves in multiple different directions. And you can see the liver is very big and actually encroaching into the thoracic cavity, why the abdomen is such a critical part of ventilation. And in fact, when you are ventilating a patient, you're actually pushing the abdomen away. So the bigger the abdomen, more pressure you have in the abdomen, the more likely you are to need higher pressure. Now here's CPAP breathing in comparison. And you can see that the chest wall actually moves very little. In fact, the abdominal more. And you can see that there's much, much more excursion in the dependent areas of the lung. So we may be actually getting a better distribution of ventilation with spontaneous breathing. And again, the key is that you pull the air into the lung. I also want to point out how the liver is squeezed by the diaphragm, and of course this assists in preload and why cardiac output might be improved by just simple spontaneous breathing. You actually squeeze all the blood out of your liver and improve venous return. That doesn't occur here, and you're more likely actually to get passive liver congestion, which is frequently a problem with mechanical ventilation. Now, certainly there's been some negative information about spontaneous breathing, especially early in ARDS. And on our clinical experience, we don't see that, but primarily we use Aprv as the mode of spontaneous breathing. And other modes may not offer the same protection that you might have with Aprv. And the reason might be that the ventilation is actually much more complicated. In fact, the control of breathing in the Handbook of Physiology, at least 400 pages are dedicated to that. So it's beyond the simple notion of transpulmonary pressure. In other words, the lung or the diaphragm does not generate just transpulmonary pressure on its own. In fact, the brain is what controls all these things. And there's multiple drivers and feedback loops that actually constrain the effort that the musculature, in particular the diaphragm, actually creates. And this is why normal breathing is different than mechanical ventilation. So if we just simply look at pleural pressure, as you increase your lung volume, you automatically decrease the ability to generate transpulmonary pressure. Now remember that Aprv has a different lung volume overall than, say, ARDS-net ventilation, which is going to be lower lung volume in general. And so spontaneous breathing might behave differently in terms of the pressure, the amount of pressure you're able to actually generate. And as you get closer and closer to your optimal lung volume. In fact, as you improve people's lung volume, not tidal volume, lung volume, It relieves generally the drive to breathe as well. Again, this is all very elaborate feedback system that has to do with stretch receptors, blood gases, all kinds of feedback, because the respiratory muscles don't just contract, they're actually controlled by the brain and all the feedback that occurs. So it's much more complicated than simply transpulmonary pressure. Now, if you look back at the airway profile, and again, think of airway profile here as generating a notion of mean airway pressure or even mean alveolar pressure, you can see that the mean alveolar pressure is going to be higher in APRV than it is in conventional ventilation. Therefore, the lung volume, the pressure generated, is going to be much less. In fact, this is a patient on ARDSNet, and if you look carefully at ARDSNet patients, I think you might see a few things. One of the things that you'll see is they can actually pull the airway pressure down. In fact, here's the PEEP level, and the patient begins their inflation with a pleural pressure deflection, actually dropping the PEEP level, and the patient actually continues to suck during the inspiratory phase and continue during the back end. Now, that patient is developing a tremendous amount of negative pressure or transpulmonary pressure, and probably because their lung volume is less than optimal. Not tidal volume, but lung volume. In fact, I'll just show you an example of an ARDSNet patient. And if you look at patients who are breathing, you might see that their sternum actually gets sucked in because of flow limitation. And flow limitation is a big cause of distress or dyspnea in a ventilated patient. In fact, there's a recent study that suggests that's one of the biggest things, the flow limitation. That's one of the key things you need to do to actually precisely control volume. In fact, that's the best way to control volume. Now you can see this patient, their sternum is actually going down as they inspire. Now that shouldn't happen, and it actually takes a lot of pleural pressure to drop an adult sternum. An adult, the chest is fused by age 18, so it's very difficult to actually take the rigid thorax and collapse it inward. And this patient might just simply need more lung volume. Now here's a patient on CPAP, and one of the things that's clear about CPAP breathing is that as your lung volume goes up, your inspiratory muscles, the effort your inspiratory muscles put out diminishes. In fact, this is one of the reasons why in the early 80s, CPAP was used to unload the inspiratory muscle loading that occurs in COPD, because it generally recruits your expiratory muscles, and it keeps your inspiratory muscles very, very quiet. In fact, this is typical of CPAP breathing and APRV breathing, where what you see is really the abdomen moving. You see very little upper chest movement, because there's no need for inspiratory muscles, and the diaphragm just simply moves back and forth without a lot of tremendous transpulmonary forces. And you'll see in a second here, this patient is breathing on CPAP, and actually we're about to extubate this patient. This is post-op multiple gunshot wounds, and you can see that he doesn't need a ventilator anymore. And this comes back to FRC, and FRC is very, very critical, and I think I sometimes refer it as the forgotten lung volume, because it's an important lung volume, and it's about 30 mLs per kg, and this helps our lungs stay stable. It changes how much force you have to use to breathe, how comfortable you are breathing. So FRC, or where we begin our breath, is very, very important. And just as an example, your average 70-kilogram man would certainly have a lung volume, or FRC, the size of a big Coke bottle there. And this is why compliance is so important. In fact, compliance means that the amount of pressure you generate is much less. In other words, even if the volumes are bigger, if you're on the compliant part of your pressure volume curve, then you actually need very little pressure change. And it's really the extremes of lung volume, whether too high or too little, that cause a lot of the pressure changes that need to occur in the respiratory system. And that's why the FRC is typically in healthy lungs above the closing volume of the lung. In other words, our lungs don't collapse as we exhale. In fact, they stay opened. And of course, when you do have airway closure, what happens is people get distressed and they keep trying to pull their lung volume up, and that can certainly be restored by decreasing the elastic work of breathing with some CPAP maneuver or airway pressure maneuver that allows the lung to be above the FRC point. Now here's another patient, and this patient is actually, I don't know if you can see this, well, let's see. Okay, here we go. This patient is actually on a CPAP level or a P high of 35. And you can see the patient is comfortably breathing. And actually the volumes are quite large. The spontaneous breaths are quite large. And you might say, my goodness, that's really high transpulmonary pressure and a lot of lung distension. But let me just describe this patient a little bit better. This is a patient who's almost just under 300 kilograms, who's had massive resuscitation because of hemorrhage, has massive anasarca, and their transpulmonary pressure is likely to be significantly less because of the body habitus and the resuscitation they receive. So what this is doing, this 35, is actually creating a more compliant portion of the patient's ability to ventilate. And as such, it takes very little effort. You can see that the airway profile barely changes. There's no massive sucking down of the airway pressure that you would see as you develop a lot of transpulmonary pressure. And the patient is actually doing 50% of their minute ventilation. And this is typically what we do with patients. We almost never want to abandon spontaneous breathing. We let these patients breathe. And progressively, as we increase their CPAP time, see if this plays here. Okay, as we increase their CPAP time, what happens is the minute ventilation transfers from the machine to the patient. So right now the patient is doing 50% of the minute ventilation. You see 9 liters versus 4. And as you wean them, the CPAP block gets bigger and bigger. Eventually, we've transferred all the minute ventilation to the patient over time. And this is why we actually begin weaning right away. This is one of the reasons why I believe that mixing modes or applying pressure support to APRV is dangerous and perhaps doesn't even make sense from a physiologic perspective. First, from a physiologic perspective, anytime you add pressure support, you actually are going to change the flow pattern from this typical sinusoidal pattern of spontaneous breathing to a decelerating flow. Second, all the limitations and the feedback that the brain has to control the respiratory muscles are overridden because now you can force airway pressure onto the patient, whereas the natural sort of limitation as lung volume increases, the power that the diaphragm can generate diminishes, is overridden. And that's why I never use pressure support when we use APRV, and I think that's really important. By the way, this is with tube compensation. Important thing about tube compensation is that it does not disturb the flow pattern. It keeps it sinusoidal, and the reason for that, it is proportional to the effort, whereas pressure support is not proportional to the effort. So let me just summarize our clinical experience. Our clinical experience is very large, and that we have noted a significant reduction in our ARDS mortality, institutional, uncontrolled, but many of our patients receive massive resuscitation, are in shock, and we have a progressively increasing ISS score. In addition, our patients are getting older and older, just like everybody else's patients. We use a tremendous amount of blood products, but we are seeing that the early application of APRV prevents ARDS in trauma. At least that's our clinical observation. So the question is, can we extract more information? And this has led us to taking this hypothesis to the lab and using a large animal model to translate the shock trauma clinical experience. And this is where we have collaborated with Gary Neiman, which of course is a fantastic lab. And here's a brief summary of the use. So it's a large animal model, as I mentioned. It's a 48-hour experiment, which is and I think very important, because many studies are done on cell cultures, are done on small models like a mouse model, and of course they don't do it for a very long period of time. The longer you do it, the more likely I believe you see the actual manifestations that we see clinically. One of the reasons why perhaps we don't have a lot of good translational information in our experimental to clinical data. This is a two-hit model, so they developed severe sepsis because of fecal peritonitis combined with superior mesenteric artery clamping that produces gut ischemia and reperfusion injury. All these animals are polybacteremic with all kinds of organisms, and of course we manage them for the full 48 hours just like you would manage a patient in the ICU. The nice thing about this animal model is after 48 hours, it has a 100% ARDS rate by blood gases, by histology, and by lung edema. These patients are severely unstable, and they get a tremendous amount of fluid to keep them alive during the 48 hours. In fact, they get 1 to 2 liters per kilogram within the 48 hours. So that's a tremendous amount of volume resuscitation, very much mimicking our shock trauma patients because they're in shock from hemorrhage and polytrauma. Now, just a quick review. This is just a representation of their shock state. The lactate goes up and down, up and down. We frequently have to re-resuscitate these pigs during the 48 hours. Here's just an example of the fluid resuscitation. You can see as we go into the experiment, the minimum amount of hourly fluid is 500 cc's, minimum amount, and sometimes exceeding that per hour. And here's some of the information. Now we've added to this, and I apologize we haven't updated the slide here. So we have another ARDSNet ARDSNet pig, and we have another APRV pig. And let me just explain what these groups are. Control is for the duration of the experiment, and these animals are just ventilated. We have the non-protective ventilation, which is this line here, and these are low PEEP 10 ml per kg tidal volume, and we have ARDSNet group, and we have the black is the APRV group. And what we can see is that the PO2 FiO2 ratio is actually preserved throughout the experiment, whereas it tends to decline over time. Now these animals are typically on 21%, except many animals later on require higher FiO2. The other curious thing is that the mortality for the ARDSNet so far they weren't able to finish the experiment in 2 of the animals. They actually did not survive to necroscopy. So by PF ratios, we have ARDS except for the APRV group. Now lung compliance, you can see that again up here is APRV, and the lung compliance stays relatively stable throughout the experiment, suggesting that the lungs perhaps healthier. Now at necroscopy, if you look at lung weights, you can see that here's APRV black and here's ARDSNet. So we have a little bit more lung water. Here's the non-protective group, in other words, low PEEP and 10 ml per kg tidal volume. Liver is less edematous or weighs less, and certainly many people have been concerned about passive congestion of the liver or decreasing cardiac output with that extended T-high period, but it doesn't seem to be creating any more edema in the liver than just how sick and massive fluid resuscitation these animals receive. Same thing for the kidneys and the intestines and the spleen. So overall, lung water is not worsened in APRV. Actually might be a little bit better than ARDSNet. Now here's the gross histology. This is the control group. Now this is looking at, again, 10 mL's low PEEP strategy, and you can see some atelectatic areas of the lung, pneumothorax here, barotrauma, and of course just very angry hemorrhagic lung. This is the Ardsnet group here. You can see some bullous areas of the lung and some hemorrhage and some overall inflammation of the lung. Here's a more recent Ardsnet animal, and this is the cross-section of the lung. You can see that the airways are full. These are the major airways. A lot of gelatinous material in the interlobular fissures. And, of course, a lot of airway closure or collapse, where you see a lot of deep, engorged pink lung, purple lung. And here's 48 hours after APRV. So far, our APRV animals, their lungs are actually pink and almost perfect looking. And here's just an example of a necroscopy where you can see how injured the bowel is. This is the small intestine here, distended. And you can see that the lung is, again, healthy looking comparatively compared to the other models. Now, again, these are 48 hours of septic shock with massive resuscitation. And this is another view of the APRV lungs. Just a quick comparison, and please note that the tidal volumes are 10 mLs per kg in the APRV group. In other words, the release volumes are 10 mLs per kg versus the control, the Ardsnet group, and the APRV group. Now, what we do see in some of the other animals on cross-section is that the surfactant seems to be already in the airway and oozing out of the distal air spaces. The APRV lungs, we don't see that, and we actually have to fetch the surfactant out by lavage. So this is the lavage of the surfactant in the APRV lung post 48-hour sepsis and necroscopy. Here's just a quick comparison of the histology. You can see the histology control versus APRV, relatively preserved architecture. You do see some increased edema or cuffing around the bronchus, which is around the blood vessel. You see perivascular edema, which appears to be occurring from all the resuscitation, but the air spaces, the distal air spaces in APRV seem to be preserved. In other words, they're one layer thick, and they don't have nearly the infiltration and the thickness that you would tend to see with control ventilation. And here you can see intraalveolar filling that you don't see in the Ardsnet, in the APRV group. In fact, this is a comparison between an uninjured pig lung compared to the 48-hour septic, shock, massive resuscitation APRV lung. You see that there's fluid here, expansion of the perivascular space, intralobular septum compared to here, than more normal, but otherwise the architecture on high magnification looks very, very similar to a naive or normal lung. This is, of course, the lab at SUNY, and somewhere in here is Gary Neiman. There he is. It's a tremendous lab to work with, and I consider them my second family. And this has led, of course, to a lot of interesting questions, which we hopefully will be working on to answer. And so from an experimental perspective, this is some of the key observations that we've made, that APRV prevents distal airspace edema. We see very little edema. In fact, the lungs in APRV float. They don't sink, suggesting that the alveolar gas volume is preserved, whereas in the other modes it may be replaced and the surfactant may have sort of destabilized the lung. We don't see alveolar edema in the setting of increased permeability, a septic model, which should increase lung capillary permeability, and with massive volume resuscitation, which by itself can cause lung edema, but we don't see distal airspace edema. We tend to see less inflammation and neutrophil recruitment, and perhaps more alveolar stability prevents the recurrent opening and closing of airways that might actually lead to more lung injury and the high amplitude ventilation. So APRV may be actually producing a very, very limited amplitude ventilation. And of course, as you can see histologically, the lung architecture is preserved, which may be important. And I want to just come back to one of the potential mechanisms and why the airway profile might be very important to stabilize the lung, and why the methodology is important. Now, if you look at interstitial pressure in the lung. The interstitial space of the lung is actually a very low compartment system. And as you develop edema, as you make lung edema, you can see that the interstitial pressure rises. And you can see here that as you create more edema, whether it's hydraulic volume or lesional, which is permeability, you develop more pressure in the interstitial space. Then all of a sudden, the pressure drops. And you can see that the lung, as the lung gets heavier, as it accumulates fluid, the pressure stays very, very low. So the pressure of increased volume in the lung, edema in the lung, doesn't result in a greater pressure than zero in the interstitium. And this may be one of the safety factors of the lung to prevent the distal air spaces from getting edematous. And what ends up happening is that as the airway pressure, as the interstitial pressure increases, it actually tears apart the extracellular matrix, widening the lung and actually destroying some of the key features of the lung and actually resulting in forcing the lung to remodel itself, which is associated with all kinds of growth factors and potentially leading to fibrosis, which we know is a sequela of lung injury, severe ARDS. Now, what APRV might be doing is it's actually, because it's almost always present, it's tamponading and not allowing the interstitium to herniate or to rip apart, keeping that interstitial space preserved and funneling water or lung edema away from the distal air spaces towards the central vasculature. So this might be an interesting idea, is actually preventing ARDS, because certainly we've had a hard time treating ARDS. It certainly still kills a lot of patients nationally, worldwide. And so preventing it may be an alternative approach. Now, certainly there's drugs that can prevent ARDS in an animal model, activated protein C, modified tetracyclines, ARBs. They've all been shown in animal models to prevent ARDS. But can the ventilator be used as a drug, as a phrase that Gary Neiman has coined? And I tend to agree with him that perhaps the ventilator, and through some mechanism, if applied early, can actually prevent the lung from getting edematous, which is really the hallmark of ARDS. It's intraalveolar flooding or edema. And so maybe we might have an alternative approach to ventilation. Thank you very much for your attention.
Dr. Bashi, let me take this opportunity while we wait for the chat function to open to thank you for this excellent presentation. I believe the high turnout very much proved the interest in this topic. And if I could ask Penny now to open the chat window so that the participants can ask their questions in written form. That would be great. Right now we cannot see the chat function. Now it is opening. So we will start the question and answer session now. Thank you.
Okay, so we have a question. I'll read these in order here. Why has the big clinical trial happened? I don't know that a big clinical trial has happened. We are actually in the process of doing an institutional trial, but I think one of the important things that need to be considered is the method of application. And certainly if you read the method section of a lot of studies on APRV, old and new, you will see that they vary quite a bit, and I think that's important. You certainly can't have, for example, low tidal volume strategy without focusing on just a certain tidal volume. Okay, we have another question here. Camille has asked, what kind of sedation protocol do we use when placing patients on APRV? And what we typically do is we try to balance the patient's sedation, pain control, delirium control with spontaneous breathing. So we use a various spectrum of medication that allows us to achieve all of those. In other words, if we have to oversedate and we lose the ability to breathe, we either adjust the medication or we use an alternative agent. We use the RASS scale, and we tend to use a lot of dexmedetomidine, which has no respiratory depression. So we use a lot of that particular approach to ventilation. I think the next question is from Woody, and it's have you seen an increase in APRV use in the U.S.? I would have to say yes. Of course, we train a lot of people at University of Maryland Shock Trauma, but I think overall APRV is becoming a little bit more, people are a little bit more interested in it. And so I think the answer is yes. And from what I understand, more and more people certainly call me and ask me more and more questions about it. So my answer would be yes. Next question is from Lisa. And how do you determine what settings to start with in APRV? I think the short answer is, how do you determine settings in any mode you use? And it's very similar to setting a pressure, and we go from there. One of the key differences, though, in APRV is that we are controlling end expiratory lung volume with time, and the reason why you use time is because the lung becomes potentially more stable this way, and we can actually trend it. We can look at the end expiratory lung volume with the flow graphics of the flow time curve, and we use the flow time curve to set the right pressure, because the airflow that's coming out of the lung is going to be dictated by the recoil of the chest and abdomen and lung, and the downstream resistance, which is the endotracheal tube, all of which vary from patient to patient. So you can watch this and see what happens. The next question is from Diane Knight, which is, how does APRV affect ICP? And I would tell you that in our experience in our neurotrauma unit and with our head-injured multi-trauma patients, we don't see an adverse effect on ICPs. It has a lot to do with the lung itself. If you try to use any method of ventilation that increases mean airway pressure, where you actually don't need that mean airway pressure, in other words, the lung is healthy, then you actually can cause more venous compression. Whereas if the lung is actually diseased and actually requires, whether it's PEEP or inverse ratio or APRV, then you generally have better lung recruitment and better ICP management. In fact, we have a case presentation coming up just on that. I'm sorry, I missed a question. It says, what are your thoughts about chest wall stability and rib plating techniques? Certainly that's been done in patients, and there's some data that suggests that might be small series, I think from the Swiss, that suggests that might be beneficial. We have not used that routinely, and again, the lung volume underneath those ribs is really potentially what stabilizes the lung, and why anytime you have contusions or lung injury from trauma, you want to control pain, but at the same time, you don't want to take away breathing and spontaneous ventilation, because that lets the lung sort of collapse and deflates. I want to get to as many questions as possible, so I'm reading these questions quite fast. There was another ICP question, which hopefully I addressed. Has there been any comparison to APRV and bi-level using shorter T-highs, longer T-lows? Not that I know of, and again, I believe that it's not the name of the mode that really matters. It's what you're doing with those settings, and the settings are essentially trying to mimic what occurs in the lung, which is that the injured lung or the patient being resuscitated who is at risk for collapsing their lung, they need more airway profile to keep their lung stable, because the lung takes a long time to recruit, but de-recruits very, very quickly, and hence the shorter release and longer flow. If you increase the T-low, you will probably end up de-recruiting the lung, especially if you use a P-low of 0. Remember that if you use a P-low of 0, you can actually get to 0, and that's why we actually use the flow pattern to tell us that we are not getting to 0 as the way it goes. Now, there's a question about APRV and COPD, and I would tell you that there are, as a general rule, this is most suited for acute restrictive lung disease. I actually use APRV on COPD patients, but that's a whole nother discussion, not focused on what we talked about today, and the settings would be in fact different for the COPD patients. But it piggybacks on a lot of the work looking at CPAP, inspiratory muscle fatigue, inspiratory muscle unloading, getting the COPD to use their expiratory muscles to actively exhale, and basically setting your P high to deal with intrinsic PEEP or to decrease the dynamic hyperinflation they have. There's a question about where is the latest information being published. You know, we're in the middle of preparing some manuscripts about the whole idea of APRV preventing ARDS and some of the experimental data that I've showed you. We have inflammatory markers coming. We have more histology coming. So I showed you sort of a brief view of that, but hopefully within the next year there should be some publications on this. The next question is APRV used in fully sedated patients? The answer is yes, and I use it actually quite frequently in brain dead patients, and actually we have a very high rate of lung recovery in Maryland and many other states that have used APRV to try to recruit lungs, because remember, part of it is the pressure time profile of APRV that actually allows you to stabilize the lung. So we certainly can use it if the patient's not breathing. Next question is APRV successfully used in neonates? I think the neonate is actually an ideal candidate because they tend to grunt to recruit their lung on expiration, and to some extent the neonate needs a glottis to grunt against, and the CPAP level of APRV mimics a glottis, and that may actually help them recruit their lung. And certainly we have several, I personally have several experiences with neonatal patients. It's a mode that neonatologists are very comfortable with in the sense of nasal CPAP, so it would transition very easily to using that in the NICU. How do you wean from APRV is the next question, and I sort of touched on this. I have to say the presentation I gave you today was really a very condensed version, and all of these particular areas can be expanded to be at least 2-hour talks each session. So just to summarize the weaning, you progressively go from CPAP with a release phase, or intermittent CPAP, or APRV, whatever you want to call it, to a progressive CPAP phase. And as you decrease the releases and you increase the CPAP block, what you're doing is you're slowly transferring the work of breathing systematically, progressively, several times a day, once a day, whatever you like, to straight CPAP. They get sick, you go back to APRV. They get better, you go towards CPAP. Once you get to CPAP, which typically we switch over to CPAP once your P high is approaching the 20s, high teens, and your minute ventilation. Once your CPAP, not sure if anyone can hear me. Okay, is the sound back? Can you hear me? Okay, good. I'm sorry our sound went back. I'm not sure what you heard about the weaning, but again, I'll summarize the progressive CPAP weaning, APRV to CPAP weaning, because APRV, in fact, is a type of CPAP. So you just simply morph into CPAP by stretching out the T high, the CPAP block gets bigger, the amount of minute ventilation done by the patient increases progressively, and the patient tells you whether they're loaded or not. And once we have a P-low around 20 or in the high teens, and the patient is doing at least 50 to 60, 70% of their minute ventilation, then we can generally switch over to CPAP. Next questions: are multiple recruitment maneuvers necessary? Why not just do 1 or 2 recruitment maneuvers, then manage with ARDSnet? This can reduce the damaging effect of having continuous high mean airway pressure. Well, in our experiments in our patients, we're not really seeing the damaging effect of continuous high airway pressure nor tidal volume. If you recall in the presentation, we used significantly higher tidal volumes than what is typically used in ARDSnet, 10 mLs, 15 mLs, and we didn't see that. In fact, we saw more lung injury in the ARDSnet model. Remember, recruitment maneuvers are intermittent and they don't last. And certainly recruiting the lung undergoes probably a lot of stress before you actually recruit the lung. When the lung is recruited, that's when the strain actually goes down. The process of recruiting, the strain is probably going up in the lung. The next question is, can you utilize a timed release approach to paralyzed patients? I think the answer, if I understand it correctly, is yes, you can, because remember that instead of setting a rate, you are essentially indirectly doing that by creating a cycle time. The T high, let's say, is 5.5 seconds, and the T low is 0.5 seconds. That's a total of 6 seconds. That's a rate of 10. So your patient isn't going to become hypercarbic. So you can use it in post-operative patients, in brain-dead patients. You actually get a lot of ventilation during the releases. And as I mentioned, there is probably a combination of diffusion and convection going on with this mode of ventilation. You indicated that the use of APRV on all vented patients, are there any criteria that preclude APRV at shock trauma? I would say anyone who's not comfortable with it. We certainly have some attendings who are not comfortable with it, but in general, it's pretty much the standard. It certainly is still used in rescue and some other places in our hospital, but for the most part, it's intubation. I have trouble knowing when to drop P high. Do you look at 10 ml per kg tidal volumes or under that? How do you monitor the chest x-ray for hyperinflation? Do you often do chest x-ray for monitoring? We don't routinely, and a couple of things I just want to mention here. Because of the open breathing system, as you increase pressure and the lung volume increases, as long as you have not paralyzed your patient, it's one of the reasons why we don't use paralytics, your patient can exhale. In other words, as the brain senses the lung volume is too big, you use your abdominal muscles to squeeze the air out of your lung. It's called defending your lung volume, and you silence your inspiratory muscles. The chest x-ray can also be used because we can look for flattened diaphragms, and we try not to, we ensure that the diaphragms are not flat, because certainly there's lots of other things that give you that, not just the ventilator mode or the settings. It's also the airway resistance, whether it's from the native airways or the endotracheal tube, from kinks, from secretions, from the progressive increase in resistance that occurs, so on and so forth. Another question is comparison between APRV and high frequency. Not that I know of. We've certainly used APRV as our form of high frequency, and there's certainly a lot of similarities. My personal feeling is the whole idea of APRV might be that it's a mode you can use early on. I doubt you're going to routinely intubate patients and put them on the oscillator, even though they are trying to do the same thing. One is a high-flow CPAP system that sort of wiggles the pressure and volume in and out, and one is a CPAP system that releases. Another question is, at our institution, we get results in APRV and then we go back to assist control instead of weaning. What problem do you see with that? Honestly, a long time ago, we used to switch from APRV to pressure support, and we saw a lot of people, their blood gases worsening. And what we didn't really pay attention to is the fact that the minute ventilation was higher and the airway pressure was higher. So in other words, we would switch from a CPAP of 15, and then over time, as they collapsed their bases, we would find that we'd be back up to pressure support of 20, 25, and the minute ventilation was much higher. So anytime you switch, look at the cost of ventilation. It's not just the blood gas. You always have to interpret a blood gas with what it costs you to ventilate the patient. What is the inspiratory-expiratory atrophy rate of the accessory muscles due to decreased chest rise and fall? Well, you have to understand that there is still some respiratory movement in the respiratory muscles. Normally, you don't use your accessory muscles. Your accessory muscles are only recruited for distressed breathing. The main muscle is the diaphragm, and anyone who's spontaneously breathing on APRV is absolutely using their diaphragm. In fact, I would argue the converse, that we actually probably maintain the less likelihood of atrophy in those particular cases. You You don't mention any hemodynamic compromise maintaining high airway pressure during APRV. Could you comment on this? I think the question is, I think, always going to be a difficult one to answer very, very quickly, but we actually see typically an increased cardiac output in our patients. Their lactate levels tend to go down, less vasoactive use, but of course you need to be resuscitated. In fact, you may bring out the hypovolemic patient more easily. Remember that just because the blood pressure drops doesn't mean that the patient was adequately resuscitated when they were normotensive. Many people maintain their blood volume, their blood pressure, despite decreased blood volume because of catecholamines, endogenous catecholamines, something you certainly see in trauma. So you can be hypovolemic and hypertensive because of catecholamines. So I think that the key thing is we don't see lung edema. The resuscitation's not different. In fact, the ARDSNet pigs tend to get more volume overall than what we see in the other experimental models. Another question, could you comment on the primary mechanism for CO2 removal? Certainly CO2 removal, it can be done by the releases themselves, and as I mentioned, because you are essentially, if the patient is not breathing, you are breath holding, and so you're allowing gases to diffuse, and if you remember the volumetric CO2 curve, there was no sort of dead space, and typically what you see on end tidal is the delta between the end tidal and the PCO2 on the blood gas is narrowed, and so you typically have a more accurate representation on your end tidal. Once you release the airway pressure, what you're doing is convectively moving the CO2, so you actually are probably having a higher CO2 per volume content. And again, if you look back at the end, the volumetric CO2, you tend to see that. So you can certainly see an increased efficiency. Generally, our minute ventilation is much lower than conventional ventilation. In fact, the earlier study suggested a 30% reduction in minute ventilation over conventional settings. Message from Shaka Shepherd. Hello to you, and I hope to see you soon as well. Another question is, just another comment. Another comment that I guess this actually helps answer some of the question about is APRV being used more frequently. There's certainly people that say they've had similar success at their institutions. And yep, actually that's the three last comments. And then of course I want to say hello to the lab at Syracuse. We look forward to the next experiment up there. Doesn't matter how much snow you guys get, we'll still be up there. Thank you all very much for your attention.
Okay, thank you everyone, also from Dragar's side again, and in particular, of course, to you, Dr. Abashi. One final note to the US participants. We did type in the email address of our marketing director, Edwin Coombs, whom to please send the evaluation forms to, so you can receive the full accreditation for this class. Dr. Abashi has agreed to stay online to take off record a few further questions, if there are any coming up. And right now I'm just checking, no further questions, so we're closing the official question and answer session now. And thank you all for your participation and time, and hope you enjoyed this webinar. Thank you very much, and bye-bye.